السلام عليكم ورحمة الله وبركاته. اسمي مروة Abdallah. My name is Marwa Abdallah. I'm going to present to you common pyogenic infections of the skin. It will be in two parts. This is part one. Our intended learning outcomes is to recognize the organisms commonly causing pyogenic skin infections and the specific diseases caused by them, to describe the lesions commonly seen in pyogenic infections, and to categorize the anatomical site affected within the skin, to diagnose and treat common skin infections, and to refer uncommon conditions to more qualified specialists. The diseases caused by Staph aureus or Strept pyogenes are either primary cause of certain skin diseases, or they may be a cause of secondary infections of other skin diseases such as eczema, ulcers, itchy skin conditions, etc. The specific diseases caused by direct infection of the skin by Staph aureus and Strept pyogenes have been categorized as follows. There are three diseases that can be caused by Staph aureus and or Strept pyogenes. That means when you take a scrape from the infection, from the lesion, you will find either Staph aureus or Strept pyogenes or both. And these are impetigo contagiosum, eczema, cellulitis. The diseases caused specifically by Staph are folliculitis, furunculosis, and carbuncle, actually all related to the hair follicle, and acute paronychia. While the diseases caused by Strept pyogenes are Erysipelas, bacterial intertrigo, and angular stomatitis. Let's start by ordinary impetigo contagiosum. This is the commonest form, and it is caused by Staph and or Strept. It is common in children, and it's frequent in the summer, and it can be frequently seen either around the mouth and nose or on the extremities. It starts by a vesicle, which is regarded as the primary lesion of the disease. This vesicle is so superficial that it ruptures. The vesicle appears on an erythematous base but ruptures, leaving the yellowish-brown crust. This crust is either yellowish or brown depending on the presence of blood cells in the vesicle. This then separates, leaving erythema without scarring. On examination of the regional lymph nodes, they will be enlarged and tender. Now I'm going to talk about the Bullous Impetigo. Actually, Bullous Impetigo is caused only by a certain strain of Staph, which is called type 2, FASH2 type 71. FASH2 type 71 Staphylococcus secretes a certain exotoxin, which is responsible for the production of these bulli. The organism is usually away from the lesions. It's either pharyngitis or omphalitis, the bullous lesions are usually seen on the trunk of neonates and infants. The exotoxin, exfoliatin exotoxin, separates the epidermis at the granular cell layer, which is a very superficial layer of the skin, resulting in flaccid bulli with a faint rim of erythema. And the regional lymph nodes draining these bulli are usually not enlarged. Now we are going to move to a different disease, which is eczema. The other name of eczema is ulcerative impetigo. It starts as a vesicle with erythematous base, which ruptures, leaving a dark adherent crust. This crust is overlaying a saucer-shaped ulcer with indurated violaceous margin. This heals with a scar after it goes. The local lymph nodes may be enlarged, and the most common site is the shin of the tibia. Now we are going to move to a very common conditions that you are going to encounter in many specializations as general practitioners, which are erysipelas and cellulitis. Erysipelas and cellulitis both are bacterial infections of the dermis. The systemic symptoms are present in both conditions, which are presenting by fever, anorexia, headache, and malaise. The route of entry in both conditions is a wound or macerated to web disease, usually. There is lymphatic involvement, both the small lymphatics within the dermis and the lymphangitis with lymphadenitis. The common sites for infections are face and legs, and treatment should continue for both conditions for 2 weeks. Erysipelas is caused by beta hemolytic streptococci. It affects the superficial dermis, and therefore we can see a well-demarcated lesion which is dark red in color, dusky red in color, with advancing edge, and the surface may show vesicles. Penicillins are our first choice in treatment. On the other hand, cellulitis is caused by Staph and/or Strept. It affects the deep part of the dermis and the subcutaneous tissue, and because it is deep, the margin is usually ill-defined, and it is indurated, red, hot, and tender lesion. The treatment of choice is anti-staph antibiotic. On your left, you can see erysipelas with its well-demarcated margin on the upper part, and the route of entry you can see on the lower part of the leg. Sometimes you can see, in addition to this dusky erythema, vesicles. On palpating this erythema, you will find it hot and tender to the patient. On the right side, you can find cellulitis with its ill-defined margin, where you cannot find a very distinctive border between the lesion and the normal skin. Treatment of pyogenic infections is usually depending on how severe it is. So if it is severe, as in erysipelas and cellulitis, we take, if it is caused by Strept, penicillins. If it is caused by Staph, beta-lactamase resistant antibiotics are our choice: methicillin, cloxacillin, clavulanic acid, sulbactam, etc. And the topical antibiotics chosen are usually used for mild conditions like impetigo, contagiosum, for example, and they are either fusidic acid cream or ointment, or mupirocin ointment. If you have a crust, the crust should be removed first before the topical antibiotic can work. So we use either warm olive oil or hydrogen peroxide. Potassium permanganate is a very nice antiseptic lotion. It does not leave a color, and the concentrations are ranging between 1/5,000 to 1/10,000. Usually we use the 1/8,000 concentration, and it can be used to dry oozing lesions, and also if it is warmed up in a basin, it can be used to remove the crusts. Please be ready with your questions in the next face-to-face session. Welcoming you. Bye-bye.